Thank you very much. Well, I've been at it a while, so with that comes various privileges and accolades. So I thank you for the introduction. And what I want to talk to you today is trying to combine a perspective on ischemic heart disease from the point of view of pathobiology and from translational science, showing progress that's been made, impediments, and opportunities for future directions. So we know that coronary heart disease or ischemic heart disease is a complex interplay between coronary artery disease, usually due to atherosclerosis, and the myocardium, with myocardial ischemia, more severe changes related to disruption of coronary plaques, which can lead to myocardial infarction, or acute ischemia can also trigger sudden cardiac death. Chronic ischemic heart disease involves myocardial remodeling, and with alterations in contractile patterns, ectopic foci can also generate sudden death. So in the last few years, I've reviewed my experience and that of others and produced some review articles that I'm going to use as a basis for this presentation. With regard to atherosclerosis, it is best viewed as an inflammatory response of the arterial wall to chronic repetitive injury, leading to the formation of plaques with fibrous caps and lipid-rich core, cells that are involved, or the recruitment of monocytes, which are converted into macrophages within the vessel wall, influx of low-density lipoprotein, which becomes oxidized and is taken up by the macrophages and smooth muscle cells. This process, when it involves the coronary arteries, leads to the progressive growth of coronary plaques. Certain of these plaques have been labeled as vulnerable plaques because they're subject to either ulceration of the plaque capsule or erosion, which can lead to a sudden coronary occlusion. Now, experimentally, a number of different approaches have been developed over the years, and this is a nice review article regarding various experimental models, which can involve intact myocardium, isolated heart preparations, and cell culture preparations. The contemporary era of experimental myocardial ischemic injury research began with the seminal work of Dr. Robert Jennings, and he and his colleagues produced a study in which they produced progressive temporary coronary occlusion of the left circumflex coronary artery, showing that the onset of irreversible injury required about 18 minutes and was most severe in the subendocardium, and then could progress outward from that region. Their studies identified the concept of the wavefront of necrosis following coronary occlusion, in which the necrosis progresses, as I said, from the subendocardium out into the mid-myocardium, and then in the experimental animal is complete within about 3 to 4 hours. And this time frame is very similar to many patients with ischemic heart disease, giving rise to the concept of the golden hour or the golden 90 minutes or so to try to achieve reperfusion to limit infarct size. I got involved in experimental myocardial ischemic injury research. When I was recruited by the chair of pathology at UT Southwestern, Bernie Stemridge and Jim Willerson, who had been there before me. And the chair, the dean of the medical school at that time, Fred Bonte, was told that there might be a problem with calcium accumulation in myocardial infarcts. And this was at the time when technetium pyrophosphate was being developed as a bone scanning agent. So he postulated that maybe related to altered calcium involving myocardial infarct, it could be used as a positive imaging agent for myocardial infarction. And we found in large infarcts in dogs that there was a so-called donut pattern with a bright ring of positive uptake in a central, relatively lucid area. And my first project, or asked by the radiologists and cardiologists, was to try to define the mechanism of the donut sign. And what I found is that experimental myocardial infarcts could show a morphologic evidence of distinct zones, a central, most severely ischemic zone, followed by a peripheral zone where there at least is some collateral blood flow in a border zone. And we found that in this peripheral zone, there was significant accumulation of calcium in the damaged and irreversibly injured myocytes. And this concentration at the periphery with a relatively less in the center would be the explanation for the donut sign. And here you can see ultrastructurally the pathology of evolving myocardial infarcts. Here's normal myocardium with a central nucleus, compact myofibrils and mitochondria. Severely injured myocardium shows cell swelling, clumping of the nuclear chromatin, breaks in the cell membrane, and accumulation of calcium deposits in the mitochondria. Here is advanced calcification, and here's early calcification in the border zone of cells that are being recruited toward irreversible injury. So this got me very interested in trying to make direct measurements of myocardial electrolytes in evolving cardiomyocyte injury. So we took advantage of a technique that became available at the time known as electron probe microanalysis. And what this involves is when you have a specimen in the electron microscope, and the electron beam will excite elements present in the tissue. And these elements have peaks at specific energy levels. And one can then get a spectrum of the elements that are present in the myocytes. In order to preserve soluble elements required very specialized techniques of cell culture and rapid freezing of the cells to allow for the probe analysis to take place. We were interested in the relationship of electrolyte changes to changes in the permeability and progressive damage of the cell membrane, which we thought from the electron microscopy was very important in the progression of cell injury. So what we came upon was the idea of labeling the cells with tritiated arachidonic acid, which is a 20-4 amino acid that resides normally only in the cell membrane. And the idea is that release of the arachidonic acid would be evidence of perturbation through phospholipase activation, leading to the progressive membrane injury. And this is a busy slide, but what you can see here is our electron probe data showed a progression of changes, initially from loss of potassium in the cytoplasm and mitochondria, as well as magnesium, increase in sodium, and at the 4 to 5 hour time point, when arachidonic acid started to be released, evidence of calcium accumulation. Going along with the hypothesis that increased calcium load was a significant factor in the progression from reversible to irreversible injury. Another technique that came along later was the use of fluorescent dyes such as Fura-2, which were invented by Roger Chen, who won the Nobel Prize for his discovery. And these dyes switch wavelengths when they're bound or unbound to calcium. And so the ratio at the two wavelengths is proportional to the free ionic calcium concentration in the cell. And here in these myocytes, cultured myocytes exposed to deoxyglucose and cyanide, we can see that with time, there is progressive, as the cells go into contraction, there's accumulation of calcium. Some of the cells could recover normal contractile and calcium fluxes. Others remain in a state of persistent calcium overload. And these particular cells would be in a state of irreversible injury. We also found with other techniques that it was actually possible to image calcium fluxes in these myocytes and show various responses to various types of cytokines. So based on all of this, we came up with a 3-stage model of the progression of myocardial ischemic and toxic injury. Here we see the normal cell membrane, the phospholipid bilayer, the presence of cholesterol molecules that regulate the fluidity of the membrane, and membrane protein pores that are also where the pumps and channels reside in the membrane. Stage 1 then would be a situation where we get ATP depletion, inorganic phosphate accumulation, lactate, hydrogen ion accumulation, loss of potassium, magnesium, and decrease in pH. As the process progresses, as I showed from the electron probe data, we get to a point where there's further ATP depletion and now an increase in calcium ion. This activates phospholipases, proteases, and lipids also undergo peroxidation. That then leads to a second stage in which there is nonspecific permeability of the membrane, even more electrolyte alteration and calcium loading, and then finally a stage where there are actual physical defects in the membrane. This process of pre-lethal injury leading to lethal injury with cell swelling has been termed oncosis, and which the cells suffer a sudden shock, and they are unable to initiate programmed cell death, but they undergo this process of progressive swelling due to these electrolyte changes and damage to the cell membrane, leading to eventual rupture. Other techniques that could be used to study this involve the tunnel staining for evidence of DNA ACE activation, and propyridium iodide, which could be used as a marker of cell membrane permeability. And it was shown that cardiomyocytes tend to develop both the membrane leakiness along with the turnover of the DNA. And they're following then an oncotic pathway, which can progress to other stages known as necrosis or necrobiosis. whereas non-cardiac myocytes tend to undergo apoptosis. So in my view, apoptosis has been overemphasized as a primary mechanism of myocyte death, but it can contribute to death of non-myocytic cells in the evolving infarct. Now, studies, that's basic cellular pathobiology. Then, in terms of modulators of the ischemic process, basically, after a lot of work and investigation, essentially there are two major modulatory influences. One is timely coronary reperfusion, and the second is myocardial conditioning. So myocardial reperfusion, which can be achieved today with primary coronary interventions and angioplasty, lead to a release of damage-associated molecular patterns that contribute to the response during reperfusion. Now, the variables that affect myocardial infarct size in coronary patients are the size of the occluded coronary artery and the extent of pre-existing collateral vessels and their actual perfusion, which together modulate the size of the area at risk. The second is the duration of flow deprivation and timing of recanalization. And the third is the efficacy, both in terms of reestablishment of the original arterial lumen and maintenance of the open lumen. So if we look at the process of myocardial reperfusion, the good news is that it has the ability to limit a potentially transmural infarct to a subendocardial infarct. But in the process, it's been identified a process of lethal myocardial reperfusion injury, in which myocytes that are teetering on the brink during the occlusive period with the reperfusion can undergo irreversible injury. And it's been estimated that up to 50% of the final infarct from this reperfusion is due to reperfusion injury. So yes, reperfusion is a fantastic way to limit infarct size, but the idea has been, are there other interventions that can be combined with reperfusion that can reduce it even further by limiting this reperfusion injury? Now, in terms of the mechanisms of reperfusion injury, during ischemia, the acidic pH in the cell prevents the opening of what's called the mitochondrial permeability transition pore. But with reperfusion, the normalization of the pH leads to sustained opening of the mitochondrial permeability transitional pore and calcium-mediated hypercontracture and free radical generation, which can kill these severely injured cells. The preservation of the health of the mitochondria is thought to be of seminal importance in preservation of viability of myocytes, and loss of it is thought to be a key in the development of irreversible injury. Another clinically related point is a distinction needs to be made between recanalization of a vessel and reperfusion following PCI, since reperfusion is often incomplete due to impairment of the microvascular bed, and the no reflow phenomenon is a serious complication of reperfused myocardial infarction and carries, independent from infarct size, an unfavorable prognosis. The active reperfusion, also through the release of these damps and activation of toll-like receptors, leads to activation, hyperactivation of the inflammatory response, recruitment of neutrophils in particular, that help to plug up the capillaries and contribute to the no reflow phenomenon. So some of the complex phenomena that are introduced by reperfusion, if we have a long coronary occlusion before reperfusion, we get an extensive infarct. If there's very short bouts of occlusion and reperfusion, we get a regional wall motion abnormality known as stunning. But if we have small little bouts of ischemia and reperfusion, this leads to a paradoxical sparing of the early stages of infarction that occur with prolonged occlusion. And that is known as conditioning. The postulated mechanisms of early ischemic myocardial preconditioning involve the activation of G protein-coupled receptors on the cell surface. Adenosine is one, but there are a number of others. And this leads to opening of potassium channels to the exterior on the cell membrane and into the mitochondria. And this leads to a reduced rate of ATP decline, preservation of the mitochondria. Also, it's been found that there can be a second wave of protection with conditioning known as a late window of protection due to gene activation. So there are various pathways that mediate this conditioning. One of these is known as the risk pathway, and others are the safe and the G protein coupled receptor pathways. Again, all acting to preserve the mitochondrial permeability transition pore and keep it closed. As this process has been studied, there are various types of conditioning that have been identified. Preconditioning with short periods of coronary occlusion and reperfusion immediately prior to the prolonged coronary occlusion. Delayed preconditioning, which develops within 24 hours. It's often misstated in the literature, but there's something called perconditioning, which is the conditioning stimulus applied during the ischemic event. Post-conditioning, where the one produces, rather than all of a sudden reperfusion, graduated reperfusion, which is meant to lessen the reperfusion injury. And also there's a very interesting phenomenon known as conditioning at a distance, in which one can put a blood pressure cuff on a leg or a limb, pump it up for a while, and produce ischemia in the limb while you're having a coronary occlusion, release that, and factors from the ischemic limb pump to the myocardium and can produce a conditioning effect. Gerhard Hirsch is an investigator that's done a lot of work in this area. And you can see the various types of local conditioning, preconditioning, post-conditioning, and then remote conditioning, and then attempts to use pharmacologic agents to produce conditioning. So he has identified, and I agree, that there have been two waves of cardioprotection studies. The first wave goes back into the 70s, in which in which it was initially identified that the size of the myocardial infarct, particularly if you lose 40% of the left ventricle by one or more infarcts, this carries a very bad prognosis for cardiogenic shock or intractable ventricular arrhythmias. So Braunwald in this famous paper has the idea of reduction of infarct size, an idea whose time for testing has come. Various pharmacologic agents were tried then, but the only sustained success was timely reperfusion. And then a second wave of cardioprotection studies came in the 80s after conditioning was discovered. And now we're waiting for Godot. We're waiting for the third wave of cardioprotection. So one of his papers has a nice timeline of the landmark of events in preclinical and clinical cardioprotection research. In the 70s, you can see on the preclinical side, looking for factors influencing infarct size. And on the clinical side, these autopsy studies confirmed by clinical studies about the major importance of infarct size as a determinant of prognosis. Then the finding of reperfusion being able to reduce infarct size, compounded by the problem of reperfusion injury and the no reflow phenomenon. On the clinical side, the introduction of fibrinolysis and streptokinase. And then in the 80s, percutaneous transluminal coronary angioplasty, ischemic preconditioning, subclinically showed to be able to reduce infarct size further, with adenosine as a signal, and remote ischemic preconditioning reducing infarct size on the preclinical side. And then further studies looking at these various types of conditioning models. But basically, the promise of the preclinical studies and the small proof of concept clinical studies have not translated into sustained success of conditioning protocols clinically to further reduce reperfusion injury. So I recently had the opportunity to do a umbrella review of systematic reviews in which we confirm what I just said, looking at over 200 studies that have been published in the literature, reviews in the literature. The failure of translation of cardioprotection from successful preclinical and smaller proof of concept studies to the benefit of patients led to efforts to develop and implement standards to enhance the validity and reproducibility of experimental studies. So is the problem that the experimental studies have not been carried out rigorously enough? And this is a very busy slide, but basically going back to 1985 was the first NIH effort to try to standardize preclinical animal studies. Then in this country, there was a group called the CSER group, and then in Europe, more recently, the IMPACT group. And all of these efforts have come up with very standardized approach to get reproducibility in experimental work. But unfortunately, I don't think that that is the true answer to the problem. The confounders affecting the translation of experimental findings to a reduction in major adverse events include patient characteristics, which are typically lacking in animal models, advanced age, risk factors, comorbidities, co-medications, the practical difficulties in achieving timely reperfusion within the time frame of short duration ischemia, need for interventions to address the microvascular obstruction problem, need to assess cardioprotection with the best available techniques, currently MRI, the need for large clinical trials to specifically target patients with high risk or with suboptimal reperfusion, in contrast to previous studies with low mortality and or low incidence of post-MI heart failure. Unrealistic expectations for clinical application of interventions. And the other idea that's been produced is maybe some patients have a primordial non-responsiveness to cardioprotective interventions. So let's look at what has gone on clinically over the years. And of course, the good news is going from the pre-coronary care unit to the era of coronary care units to the reperfusion era, we've seen a progressive reduction of in-hospital mortality from acute myocardial infarction. And we've seen a drop in the overall death rate from over 200,000 to less than 100. 200 per 100,000 to less than 100. So due to the sustained application of the primary, secondary, and tertiary protective measures, the death rate from coronary disease has been reduced from over 400 to 100,000, to 400 per 100,000 to 100 per 100,000 or less. Despite the substantial decrease in mortality, however, AMI mortality is still significant, and it also leads to a significant incidence of heart failure due to chronic coronary disease. In the USA, there are 8 million patients with chest pain seen in emergency departments every year. Of these, about 2.8 have evidence of an acute myocardial infarction, manifest by cardiac arrest, obvious MI, or unstable angina. The remaining 6.5 were triaged to a low probability group for further evaluation. In my view, stem cell therapies have not proved to be effective in achieving clinically meaningful reversal of pathologic myocardial remodeling. Sudden cardiac death outside of the hospital may be the initial manifestation and remains a major cause of morbidity in patients with ischemic heart disease. And chronic ischemic heart disease, therefore, is a leading cause of advanced heart failure due to myocardial remodeling and is a major group requiring advanced circulatory support or transplantation. So what can be done given the stalling of the conditioning type approaches? We have the classic differentiation of infarcts as to ST elevation MIs and non-ST elevation MIs. About in the 2000s, an approach to give more specificity to the types of infarcts came along, and that's known as the universal definition of myocardial infarction, using high sensitivity troponin for rapid diagnosis and requiring, so the high sensitivity troponin tells us we have myocardial injury, but is it ischemic injury versus myocarditis? We need to find evidence of ischemia with symptoms, changes on the EKG, imaging evidence. And here you see the type 1 myocardial infarct, which is one due to plaque erosion and rupture with thrombosis. The type 2 infarct, which is an oxygen supply demand imbalance problem, vasospasm, coronary dissection, and then the sudden death, which is an arrhythmic problem. Another recent insight has come from the fact that myocardial ischemia and infarction can occur with non-obstructive coronary arteries, so-called MINOCA, compared to myocardial ischemia and infarction with obstructive disease. So the spectrum of vascular disease has been broadened. Another insight has come from a paradigm shift from ST segment elevation MI to occlusion MI. Electrocardiogram, as we know, has been used for many years to triage patients with evolving MIs into STEMIs and non-STEMIs, with the aggressive strategy focused on the STEMIs. But with the use of the universal definition of myocardial infarction, it's been noted a worldwide increase in the incidence rate of non-STEMIs, and registries of the US and Europe now show approximately 2/3 of AMI patients are classified as non-STEMIs. So the correlates, STEMIs result from total or near total coronary occlusion, but totally occluded coronary arteries occur in approximately 25 to 30% of patients of non-STEMI. And these patients typically are assigned to delayed revascularization. This new paradigm has led to the idea that all total occlusion MIs, whether they be STEMI or non-STEMI, should be candidates for aggressive interventional therapy. Another new insight has come from the Canadian Cardiovascular Society using advanced imaging, and they have shown that they think that there are 4 different stages of MI depending upon the amount of injury and edema that can be detected by MRI. And they call stage 1 aborted MI, in which there's dysfunction with reversible loss of contractility, but viability is preserved. The stage 2 is one with necrosis and no microvascular injury. Stage 3, with 40 to 50%, have necrosis and microvascular obstruction. And the stage 4 are basically advanced hemorrhagic infarcts. So the idea is, can we use this type of imaging approach to identify patients that might do better with early intervention? So Dr. Barr is a representative of a group of emergency medicine physicians who have advanced this following idea. And here we see that the low probability AMI group that's going to triage for later evaluation. And then in the AMI group, we have ones with established infarcts, unstable angina, or sudden arrest. But in looking at these patients, he indicates that probably about half of these patients have prodromal signs or symptoms before they hit the emergency room. And so this would include the pre-hospital cardiac arrest group, the unstable angina group, and the unstable angina and MI. So this accounts for 600,000 deaths a year. And the idea is, can we cut this in half if we aggressively identify and go after these patients with prodromal symptoms? This also probably applies to patients with sudden death. I reviewed 5 pathologic studies looking at cases of sudden cardiac death. And what's of interest to note is that a very high percentage of these patients had evidence of old MIs or fibrosis, and as well as a coronary disease, suggesting that these patients have had prior episodes and somehow this is averted, they've averted or failed to reach clinical attention before the final sudden event. So here's the idea here of where we have the patient with acute chest pain, but a goodly number of these people have prodromal symptoms. And even though we're making progress in getting to the patients that do present, is there a way to get these patients with prodromal symptoms to medical attention early? So the conclusions are that the current state of ischemic heart disease warrants a two-pronged approach for further reduction in morbidity and mortality. One arm is support for continued basic pathologic and translational research to identify new approaches to cardioprotection. The second is to advance clinical diagnosis and management based on evidence-based effective approaches, including rapid diagnosis of subtypes of acute coronary syndromes, unstable angina pectoris, and AMI, through the application of the universal definition of MI and the Canadian System of Advanced Imaging. And then the implementation of the occlusion, non-occlusion paradigm to include aggressive management of all STEMI and the 1/3 of non-STEMI with total occlusions. And then the rapid identification of prodromal stuttering MI and implementation of aggressive therapy in this group who present to medical attention before the onset of MI. And then a public health campaign to get patients with prodromal symptoms to medical attention before the occurrence of ventricular fibrillation-induced sudden cardiac death. Those are my thoughts, and thank you for your attention. I'll be happy to answer your questions or try to answer your questions.